Good afternoon, everyone at Icarus. It's a pleasure to be here to talk to you about the state of the art. Where are we in 2021 with carotid stenting? My conflicts of interest are shown on this slide. When this all began back in 1994, this is how we did it. We didn't know what we were doing in terms of patient selection. And this is the very first case in that IRB-approved protocol at the University of Alabama in 1994. And we've made such great progress since this time. There have been literally hundreds of papers and unparalleled level 1 scientific evidence to support the use of carotid stenting in our patients. No other vascular procedure has quite been rigorously investigated like carotid stenting. So what has 30 years of experience with carotid stenting taught us? Well, it has taught us, firstly, that patient and vessel selection is the most important, and this includes the aortic arch, and we must remember this as we move forward. So operator experience has taught us that the lesion that you see on the left, or the tortuosity and angulation, is probably not what we should be treating. It should be the lesion on the right. That embolic protection and stent technology, as I'll mention, is very important. All of these reduce brain embolization, and this we are achieving in 2021 with carotid stenting, but we have not solved the aortic arch issues. So given the above, where do we stand? Well, the field is rapidly advancing. We know that long-term stroke prevention with stenting is equivalent to endarterectomy. Multiple prospective rigorous trials, CREST, Act 1, Space 2, have shown this. We know that CAS technology is rapidly improving and minor strokes are disappearing. And this is extremely important. And this is happening with mesh stents, better filters, flow reversal. One important thing that has happened is that transcarotid stenting has emerged as a challenge for percutaneous transfemoral or transradial stenting. And I firmly believe that this technology and this approach needs to be prospectively challenged in trials against carotid endarterectomy and percutaneous carotid stenting. I believe that this technology will be valuable for the 10, perhaps 15% of patients who have vasculopathic aortic arches, type 3 arches, and bad disease in the proximal common carotid vessels. So what's the evidence that CAS stenting has significantly improved over these years with experienced patient selection and technology? Well, I'm going to show you the CREST-2 registry. 2,000 patients, hundreds of operators, very rigorous study where we were able to show in the community that with good patient selection and technique and experience, operators can produce stroke and death rates of less than 1%. And I'm going to discuss all the second generation technology, fine mesh stents, better filters, and flow reversal. So this is the CREST-2 trial published in 2019. And I want you to focus on the bottom panel. Very large number of patients, very rigorous follow-up, very rigorous neurological examination of the patients. Around 1% stroke and death rates in both symptomatic and in asymptomatic patients, just about 2%. And in patients that were really ideal for carotid stenting, the ones that would be in the CREST-2 trial, if you look at the bottom right, 0.8%. This is incredibly powerful data, indicating how patient selection and technique and experience can produce these great outcomes. Because in this trial, we did not have all the new technology I'm going to discuss. I'm going to talk about the new NeuroGuard IEP system from Contago Medical, the C-Guard and Road Saver stents, occlusion and flow reversal, including the MOMO device. What is the evidence And there is such good evidence coming from my European colleagues, from all of you. And this is the CREST-2 study from Sigriano's group in Italy. Large number of patients, remarkably low stroke and death rates, under 1%, and associated reduction in DWI defects on MRI. So there's no question of how much the technology has changed since the early pivotal randomized trials in the United States and Europe were performed. This is some data from the Paladin NeuroGuard IEP system, again, showing definitively the very, very provocative DWI testing is demonstrating less embolic debris, less embolic events, better CAS outcomes. And this is wonderful work from your own Piotr Musialik, showing the use of the CGuard filter, stent, and flow reversal in this very complex lesion, an indication of how far we've come in these 30 years. The biggest opportunity, the best opportunity to prevent stroke with carotid intervention is in asymptomatic patients. This is a huge population. Let me touch on this in the last few minutes. The most important trial, randomized trial we are undertaking at the present time is the CREST-2 trial, two-arm trial comparing best medical therapy to stenting in one arm to endarterectomy in the other arm. And I'm going to show you these projections. We don't know the results, but I want you to look to the left of this slide and the brown lines, which represent what I expect to be the outcomes if we can come in with a 1% to 2% stroke and death rate at 30 days, and knowing that the stroke and death rate, or the ipsilateral stroke rate rather, over the next 4 years is 0.4%, which we know from the previous studies. And compare that to the blue lines, medical therapy. It's very clear that in asymptomatic patients that we may see the benefits when this trial is finished. We're getting close, 2/3 done, to show that revascularization is truly superior with a one and done approach compared to medical therapy. This very important paper was published last year by the Oxford group, and it gives the lie to the fact that asymptomatic patients do well on medical therapy. So the CREST-2 trial is going to have to prove it. But in their meta-analyses and in their own work, look at these very important graphs in the bottom right. You can see 15 to 20% stroke rates at 4 years in patients treated with contemporary medical therapy. So if we continue our good work and produce these very creditable outcomes, then we can benefit so many patients with carotid artery disease. So let me conclude then by saying transfemoral carotid stenting continues to march forward. With significant improvements in experience, technique, and technology, particularly fine mesh stents. I do not believe anyone should be using primitive open mesh stents in 2021. Improved filters, flow reversal, and this will prevent brain microembolization. The greatest opportunity for stroke prevention really exists in us validating the use of percutaneous, non-invasive, wide-awake patients in the use of carotid stenting. And the CREST-2 trial, I hope, when the results are out, will prove my case. Thank you very much for your attention.